Assalamu alaikum warahmatullahi wabarakatuh. How are you all, sons and daughters? And I hope all of you and your families are well and doing well. And I hope we can meet very soon. And I am very happy to meet you again in another lecture. Dear sons and daughters, our lecture today will be about the physiology of micturition and the differences. We'll talk about the anatomy of the urinary bladder and some of the differences between the male and female bladders. And we will talk later about the incontinence and incontinence, how to keep the continence, and if incontinence happens, how it can be classified, and what is the main problem here and how to deal with these problems. We said that the bladder is an organ, internal organ. It's a pelvic organ. Its main function is the storage and empty of the bladder. And it is maximum capacity of this organ is 500 cc of urine, and sometimes can reach more than this if the place and time is inappropriate to empty it. And we saw even it can reach, we saw in some cases can reach even 2000 cc of urine. We say that this is a pelvic organ. You see here in the picture that the organ is pelvic when it's empty, but when it is distensible with urine, it can reach even the site of the hypogastrium or the umbilicus. And we know that it is a muscular organ with a muscular coat, and we have a mucous membrane which is held in folds. These folds will allow the organ to be distensible when it's full with urine, except in the region which is called the trigone. The trigone is the area between it's an area in the base of the bladder, and here the area is smooth even if the bladder is empty. We have a superior angle and we have inferior angle. The superior angle represents the two openings of the ureters, and the inferior angle in which the urethra is opened. It's held in position, but it's why it's smooth, because the mucous membrane here is adherent tightly to the underlying muscular coat. The muscular coat here called the detrosa, and it is have three layers: circular, longitudinal, and another circular layer. The circular layer here is continuous with the urethra to form the internal urethral sphincter, and it is very specialized muscle. It's viscous, can have an apex and have superior and inferior lateral surfaces, and have a base and have a neck. And in the base we have what is called the trigone, and it is the line between line between the entrance of the two ureters to the bladder. And as we said, it's have a neck, and this neck is connected to the urethra, which is different in length between a male and female. We will talk here little about the differences between the male and female bladders, but you must, first of all, you must have in your mind that the blood supply and venous drainage, lymphatic drainage, and the nerve supply are the same in the male and female. We said that it have many surfaces. We have a superior surface, we have inferior lateral surface, we have base, and we have neck. We will see explain on the picture that in the base of the bladder we have the seminal vesicles and the vas differences, which separate the base of the bladder from the posterior organs. The upper part of the base of the bladder is covered with peritoneum and will form the rectovesical pouch. The lower part is separated from the rectum by the seminal vesicles and the vas deferens. And we have the superior surface of the bladder, which is related to the coils of the intestine, and the inferolateral we see here in this picture. You see, in this picture you see that it is related, the superior surface is related to the coils of the intestine, while the inferolateral surface of the bladder is related to the pubis bone, and it is separated from it by a band of fat. While we say the base, we have two parts in the base. We have the superior part, which form the vesicorectal pouch, and the lower part is separated from the rectum by the vas deferens and by the seminal vesicles. And we have the neck of the bladder. This is faced inferiorly, and it's in the male. We see in this picture it is raised on the prostatic gland. It's held in position in male by the puboprostatic ligaments, and in the female it's held by the pubophasical ligaments. And we talk in the last slide about the trigone. We know that trigone is the area between smooth area in the base of the bladder, connecting the line between the urethral openings in the bladder and its inferior angle is the urethral orifice. Now the nerve supply of the bladder, it have sympathetic and parasympathetic nerve supply. The sympathetic nerve supply come from the lumbar ganglia through the hypogastric plexus to the first and second lumbar ganglia, while the parasympathetic via the pelvic splanchnic nerve via from the second, third, and fourth sacral nerves, and will pass to the inferior hypogastric plexus and will supply the bladder. And the most efferent, visceral efferent fibers in the bladder reach the central nervous system via the splanchnic nerves. But some of these nerves can also pass through the sympathetic nerves to the central nervous system via the second, third, and fourth nerves. We said that we have a parasympathetic and sympathetic nerve supply, and later on we will talk about how the bladder store urine by two action. The muscle must be relaxed and the sphincter must be contracted, so the urine will be stored there. And when it won't empty itself, the muscle must be contracted and the sphincter must be relaxed. I forget to tell you that the urethral sphincters, we have two urethral sphincters. One is internal urethral sphincter, which comes from the circular layer of the detrosa, and the external is a striated muscle. The parasympathetic nerve supply, which come through the splanchnic nerves and through the second, third, fourth sacral nerves, these will cause contraction of the detrosa and inhibit the action of the sphincter, so it will cause emptying of the bladder. While the old concept was that the sympathetic nerve supply is in contrast of that, yani it will cause relaxation of the detrosa and contraction of the sphincter. But now they found that the sympathetic have no role in the emptying of the bladder, but it's supply only the blood vessels. But in male and during ejaculation, it will cause severe contraction of the bladder neck, so it will prevent the seminal fluid from entering into the old concept that the. Now we will talk little about the physiology of micturition. It is a reflex action that's controlled by the higher centers in the brain. Why? Because sometimes you have an urgency to urinate, but because the place and the time is inappropriate, you can't do it. So this needs a higher and inhibitory action and higher control of them from these higher centers. And as you know, the first desire will be when the bladder have of 150 cc of urine, and will be more when there is reach 300 cc. We said that we have efferent and afferent fibers. Both of them are passing from the bladder wall to the bladder wall via the splanchnic nerves and to the second, third, and sacral nerves to the cord, to the higher centers, and from the higher centers to the cord, to the sacral nerves, and to splanchnic nerves to the bladder walls. So the efferent parasympathetic impulses, we say that it's leave the cord to the second, third, and fourth, to the splanchnic nerves, then to the hypogastric plexus, and then to the bladder wall to cause the diaphragm to contract and the sphincter to relax, and will cause emptying of the bladder. Sometimes, in some circumstances, this micturition can be aided by the contraction of the abdominal muscles to raise the intra-abdominal pressure and exert an external pressure on the bladder. In the young children, the micturition is a simple reflex that can take place anytime and any place. And when the inhibitory fibers started to reform and pass down the corticospinal tract, the voluntary control of the micturition will be started, and this will be started around the second and third year of life, and will be controlled little by little with some problems we will talk about later on, inshallah. You see here in this slide, this is very important when we will talk about later on about how the bladder is content for urine, or how the incontinence problem will begin. The physiology of the bladder wall differ from that of the neck. It's as we said, it's formed by a smooth muscle which is known as the detrosor, and it is mainly rich in beta adrenergic receptors, while the neck is rich by alpha adrenergic receptors. And the bladder here is completely formed by the smooth muscle detrosor, while the neck have two types of sphincter, which is the internal, which is formed by the smooth muscle, which is formed by the detrosor, and the external, as we said, which is an striated muscle, and this is control, the voluntary control. And here we have the bladder wall have beta rich in beta adrenergic receptors, and these are stimulated by parasympathetic nerve fibers, while the sphincter have more. So if you want to talk about the process of micturition, it starts from when the ureters started to pass the urine from the kidney to the bladder, and the ureters opening between the layers of the detrosor muscle. When the detrosor is when the bladder is filled with urine, it will be, these two ureters will be closed in a valve-like process, and will prevent the reflux of urine to the to the ureter and to the kidney. And we said that the supraspinal centers and the higher centers will stimulate the process by the hypogastric and pudendal, يعني by the autonomic nervous system and by the voluntary control. And we started to desire for يعني to void where there is 150, and this will cause the stretch receptors in the bladder wall to send impulses. And so we are and will cause these impulses, the parasympathetic control, cause the contraction of the detrosa and the relaxation of the sphincter, and we will pass the urine when the time and the place is appropriate. So you see that we can control the process of micturition because the cerebrum is able to suppress this reflex when the time and the place is inappropriate. And it's when the time and the place is appropriate, the cerebrum will relax the external sphincter and will cause the bladder to be contracted to empty its content. So we can say that the basic process of micturition can be divided into the urine is made in the kidney, and the urine is then stored in the bladder. And as we said, when the time and the place is appropriate, it will the parasympathetic supply will cause the bladder muscle to contract and the sphincter to relax, and it will be empty. And we said that we have both sympathetic from the T10 until L2, and the parasympathetic from S2 and 3 and 4. And we have adrenergic receptors, and we have alpha receptors in the sphincter. And we have also hormonal status is very important, especially in female, the estrogen status, and we will talk about later on in the incontinence. So we talk about the cycles of the cycle of the urine filling, then storage, and then emptying. How this conscious control of bladder occur? This occur by the intact coordination between the bladder and its nerve, peripheral nerve supply, symplectic nerves and pudendal nerve, and the spinal cord and the bones and the cerebrum. So the first urge to urinate is when the bladder contains 150 cc of urine, and we will start to look for appropriate place to toilet when it's become for 300. And as we said before, there is coordination between the sympathetic and parasympathetic supply to the organ to control the storage and emptying of its content. So as we said, there is a conscious control of the process of micturition by the coordination between the cerebrum, bones, spinal cord, and طبعا the peripheral nerves. We said here, we mean here the pudendal nerve. And as we said before, that the parasympathetic nerve fibers will stimulate the contraction of the detrosor muscle and just by releasing acetylcholine near this muscle. And there, at the same time, there will be an inhibitory reaction from the bones to the spinal cord and then to the urethral sphincter to cause its relaxation. If this not happen, there will be a contraction of the detrosa against a closed sphincter, and this is will called the detrusor sphincter dysnergia, and this can occur in cases of injury to the spinal cord above the S2, and these patients may require catheterization to prevent the overdistension of the bladder. As we said before, the bladder wall consisting from a smooth muscle, which is the detrusor, which is arranged in three layers: the circular, two circular, and one longitudinal, or one circular, one spiral, and the longitudinal. And we said that the circular layer will pass into the urethra to form the internal urethral sphincter, while the external urethral sphincter is a striated muscle. So this diagram will show us how the normal voiding cycle. When the bladder is full, then there will be a first ascension to void when it had 150 cc, and then when the time and place appropriate, there will be a normal desired void to void, and then will be emptied and to be filled again. The continence more in male than in female than in the male, and there's many classification, as we said. It's more in the white race more than the black race, and more in the baras women, يعني the women who have delivered, especially those who delivered normally. And there is many risk factor we will discuss about later. So we have many types of urinary incontinence. We have the main type, which we discuss here. It is the stress incontinence, and we have the urge incontinence. We have the overactive bladder. We have mixed, يعني we have urge and we have stress incontinence. We have the overflow incontinence, and we have the continuous incontinence. The stress incontinence, in which the sphincter dysfunction due to pelvic floor weakness, and here there will be involuntary loss of urine on exertion. The urge incontinence, there is uninhibited detrusal contractions even if there is a small amounts of urine, and there will be an involuntary loss of urine accompanied by يعني after the urgency. We have the mixed type that is mixed with urgency and stress incontinence. There is urethral dysfunction, يعني sphincter dysfunction, and there is also detrusal or contraction. And we have involuntary loss of urine with the urgency and with exertion. We have the overflow, and there is over distended bladder, sometimes in the diabetic neuropathy, and we can feel the bladder here. And we have the continuous incontinence in those who have vesico-vaginal fistula, especially طبعا you will see these cases in after surgery and after normal deliveries. We have the pathophysiology of the stress incontinence. We said we will discuss. This is you will see it more than the other types, and also you can see the urge incontinence. But this is the more you will see by, especially in the females and in old age. We hear the intravesical pressure overcome the closure pressure of the urethra. And there is a defect in the urethral sphincter. And this integrity of the urethra to retain the its pressure depend on the pudendal innervation. And we must have a well vascularized urethra and urethral smooth muscle mass, and we have intact serrated muscle mass, and we have intact vaginal support for the urethra from the levator and ligaments of fascia. But the risk factors for the stress incontinence, as we said, the parturition or the delivery, especially the normal deliveries, age, estrogen deficiency, age طبعا it will increase with age, and there is evidence that it's related to the other factor, which is the estrogen deficiency. As the female increases in her age, there will be an increase in estrogen deficiency, and there will be defect in this area will lead to this stress incontinence. And there is also an evidence to relate the obesity to the stress incontinence. We have also see these cases more in the pelvic support defects. Said in the race in the black, it's very less than the white race, and we have inherent factors. We can see these cases even in nulliparous women because of the collagen deficiency or defect. We have said that one of the risk factors is the age, increasing age. It's because it's associated with the using of diapers. And using of the diapers, the patient will become like a child. There is it's considered like an appropriate time and place because she wear a diaper. She can urinate any time. Or those who have delirium, or those who have infection may increase with age. With those who have atrophic changes because of the estrogen deficiency and because of the restrictive movements. Also, we have psychological causes. We have the stool impulsion, and which can cause damage to the floor here. And we have also, there is a rule for the pharmacological agents like the alpha blockers, like the doxazocine and antihypertensive drugs, which can cause by itself stress incontinence, and the angiotensin converting enzyme inhibitor, which can cause chronic cough, which aggravate the problem. We said the atrophic changes due to the estrogen deficiency, and this will lead to decrease the urethral resistance and increase the incontinence. And the women who have vaginal delivery, they are more at more risk because of the damage to the floor here. And also we talk about the inheritant factor. We see here by this picture, one of the studies shows that 1 in 3 women suffer from stress incontinence, urinary incontinence in general, and female to male ratio is 1 to 14, and it's estimated that nearby 200 million one suffer from stress incontinence or urinary incontinence in the whole world. The assessment of these patients, as any patient, other patient, is by history and by examination and by investigation. We will come to every one in slight detail. This picture shows the types of incontinence. We have here the stress incontinence, which is due to the sphincter failure in the intra or the abdominal pressure is more than the increase or weakness of the pelvic floor. And we have the urgent incontinence, involuntary contraction of the bladder muscle, and we have the overflow due to blockage of the urethra, and we have the neurogenic due to the impairing of the neural supply of the. This is another picture to show this. We have the stress incontinence due to increase in abdominal pressure. We have the urge incontinence due to oversensitivity of the bladder due to infection, or there is a neurogenic disorder. And we have the overflow. There is a urethral blockage, and the bladder is unable to empty itself. We start by the history, and the history is by asking about the frequency of micturition and its inclusion to the patient. This can be unreliable, and we can, instead of that, we can ask the patient to calculate the fluid they pass during the day for 2 to 3 days. Of course, if the patient taking a lot of fluid, she will pass or he will pass a lot of fluid or urine. There is another way. If she is complaining of continence and she uses pads to overcome this problem, we can ask her to the number of the pads she use and per day. And we ask her also about the precipitating factors like the coughing, sneezing, or constipation. The urgency and frequency of the urine can become worse if there is an inflammation process. We said in the last slide that this can be increased, urgency and frequency can be increased if there is intravesical inflammation, and this typically occur in urinary tract infection, and also can occur if there is a stone, if there is a tumor. We must, if their patient have a persistent symptoms, if it's not embracing, we can ask the patient about the history of bedwetting during childhood, and if there is previous surgery for the pelvic floor, if there is operations like the hysterectomy or rectal surgeries. We will ask her about the childbirth, special difficult labors, and also sometimes this can cause sphincter damage. We can ask if there is any previous continence surgery, and because this can affect if we decide another surgery for the patient. The physical examination of the patient as a physical examination of any other patient. We start by the general inspection, by the this may be the patient is diabetic or have the patient is complaining if she had a urinary tract infection. The things we have to look for is the hair weight, the basal body mass index. This is very important because there is a strong evidence between the increased body weight and the incontinence. We need to do a general abdominal examination to examine the size of the bladder, if there is over distension, if there is obstruction, if there is a tumor, if there is tenderness. We also we say that the general assessment of the patient and the patient mobility, and this is very important for the patient who are decided to have a surgery, or if they need to do a catheterization, if they can do it for themselves or not. We have to do a neurological examination because, as we said, if there is a defect in the nerve supply to the bladder, there will be also one of the causes of the continence and the failure of remaining continence in the area. The pelvic examination, we said that we do for the patient general assessment, abdominal examination, neurological examination. Here we want to do pelvic examination for the patient. First of all, to assess if there is really there is a urinary leakage. We ask the patient to cough. We examine their thrombosity if there is a previous surgery, and we want to assess the bladder volume if it's over-distended or not. And we want to assess the levator and knife if there is any injury of the childbirth and cause defect in the area. If there is a vaginal discharge, and this can cause infection and aggravate the problem. If there is estrogen deficiency, like in the menopausal woman, if there is any defect in the perineum, like after deliveries, if there is prolapse and if there is a pelvic mass, also can affect. Then after we decide that this patient have a real problem of incontinence, we'll send her for investigation. طبعا first of all, and the most important investigation, the micturition urine, to exclude if there is a urinary tract infection. And also, if we decide to do a urodynamic study for the patient, and if she had this urodynamic study in itself have a risk of 1% risk of urinary tract infection. If the patient have a urinary tract infection, يعني, it will be increased. We ask her for urinary diary, يعني this simple paper to write in 2-3 days write the amount of drink she or he take, and the amount of urine she pass during the day, and better to do it for 2-3 days. So another investigation used to assess if the patient really have urine incontinence is the bath test, and using baths to assess if there is a urine loss of or not. And there is two types: the short type, less than 2 hours, and the long type, which is more than 24 hours. Sometimes they use it for 2 to 3 days. And the bud is weighted before and after the use. If there is an increase in the weight of the bud of 1.3 gram, it will consider positive. It can't assess the type of incontinence, and sometimes they use some types of dyes if there is to distinguish if this is a really urine loss or a vaginal discharge. And one of these dyes which is used here is the pyrimedium. Another investigation we are using here, we will use the uroflowmetry, and this is a simple and non-invasive investigation. It can be used in the outpatient setting, and in those patients who are complaining from voiding difficulties, retention, neuropathy, and prior to incontinence, to continence surgery. We have many parameters here. We have the flow rate, which is the volume of urine expelled from the bladder in each second, and we have the flow time, which is the duration of void, and we have the maximum flow rate, which is the maximum rate of flow, and average flow, which is the volume of urine voided divided by the flow time, and we have the total volume voided calculated from the area under the flow rate. And the most two useful parameters are the maximum flow rate and the voided volume, and which should be more than 150 ml. Here you see this is the flow meter. The patient is sitting here and asked to urinate. We said that we use it in the patient who are complaining from urinary difficulties and neuropathies. And this is the chart. This is a transducer. There is a transducer which is connecting to another instrument. We will have this chart and the parameters used here to assess the condition of the patient. There is a weakness in the detrosa, and the fourth chart, there is a flat or plateau pattern, and this is caused by prolonged voiding, and there may be a stricture of the urethra. So we said that the first urodynamic study, one of the urodynamic studies we use here is the cystometry, and the plot or the study with it is called the cystometrogram. And normally the detrosa or the bladder pressure must be remain relatively static and very little increase with the filling. If it is started to increase, this means there is an or detrusor in contractility, and in these cases the patient have a poor compliance, and the patient will start to have a desire to urinate, and even may have urge incontinence when the bladder is full. So we can consider this as detrusor instability or to be significant when the detrusor pressure is above the baseline of 15 centimeter. The woman here is asked to void on a flow meter and then examined with the residual urine is noted on catheterization. Then during the filling, the woman, طبعا we said we use a filling line by the normal saline. We ask the patient to indicate her first desire to void and and the volume of these events are noted. There is an overactivity of the bladder and the differentiation during filling, and if there is stress incontinence, also all are measured and noted. Systolic detrusal contraction and their association with urgency is also noted. And if there is any precipitating factor, like we ask her طبعا for coughing or we run a water in front of her, is also noted. And if there is any symptomatic detrusor pressure on standing, is again is recorded. After at the end of the filling line is removed and the woman stand up and she's asked to cough, and if there is any leaking it will be noted. And we must here avoid the artifact from moving the lines. We said that we run our water in front here of her, and hand washing are performed to not any leaking, and then she's asked to void, and the pressure line is still in place. So you see here urodynamic trace. This is a normal urodynamic trace. We said that the parameters used here are the intravesical. You see that there is three lines here, the intravesical and the intra-abdominal, and we have the detrusor pressure by subtracting the abdominal pressure from the intravesical pressure. And we have also sometimes we use the flow rate, and filling and voiding volumes are also measured. This you see here normal flow rate. The basal cystometrogram, and these are the micturition contraction, and it is used by the we see here the intravesical pressure by centimeter in water, and the volume which is voided. We have also another urodynamic study which is called outflow urodynamics. This is enable the detrusor pressure to be measured during voiding. After filling the bladder, we ask the patient to cough or to sneeze, and we will note if there is any stress leaking of urine with a full bladder. If there is a high pressure, and we by the tool the instrument record a high pressure in the bladder, with low flow rate. This means that the patient is complaining from obstruction, like in the male, if there is a prostatic enlargement or obstruction. The normal voiding pressure should be less than 50 centimeter with a flow rate of 15 centimeter per second. And in women, this is less than this, maybe as little as 25 centimeter of water, because of the less resistant of the urethra. In the obstructed patient, يعني مثلا for a male with a prostatic obstruction, this can reach even the high pressure can reach even more than 100 cc of water with a very flow rate is less than 10 centimeter, 10 ml per second. And sometimes in contrast, the patient have a low bladder pressure, sorry, and low flow rate, and these patients are complaining from the problem in the trouser itself. So this patient, why we do this? Because to know if this patient will be benefit from the surgery or not. This patient with a flow rate less than 10 ml per second will not get benefit from the surgery, for example, from prostatic surgery, because the problem is in the muscle itself. We have another investigations for these patients, like radiology, of course. We have plain abdominal x-ray. If there is any stone causing this problem or passing down, if there is a mass, it can be seen sometimes. We sometimes can do intravenous urograph and sometimes computed tomography urogram for this patient. We can do also video cystourethropy, and this is by pushing a dye and do an x-ray for the bladder, and we notice if there is any leakage, if there is a fistula, if there is any problem can be noticed by this. We can also send them for ultrasound. We can also do cystourethropy for this patient, and sometimes we can do electrophysiological tests like electromyography and sacral flexography. As we said, we may have the problem in the detrusor itself, so we send the patient for electromyography for the tracing of the detrusor itself. Now we will come to the treatment of this patient. Inshallah, in the future, you will see that these patients are, there is a wide range of these patients in our clinics, especially in the gynae clinics and the urology clinics. Most of, for these women, they have a social problem with this incontinence. And sometimes they can't go outside because of the problem of incontinence. Yani imagine the patient have incontinence for urine and the bad smell, so she will lose her esteem. So you can start with simple measures like the conservative treatments for this patient. We can ask the patient to have maintain normal body mass index. If she is a smoker, to stop smoking. If she have a lot of caffeine intake, because caffeine drinks are very irritating to the bladder. We ask her to increase hair fluid intake and treating constipation, treating the chronic cough, or the change if she had a treatment causing these problems, like the cough, chronic cough, or the problem with some drugs which can cause itself the stress incontinence. We can refer her to her doctor to change these drugs. We have another type of treatment which is called pelvic floor exercise, and this can be very useful especially for the female patient, especially for the old patient and the paras patient, and these are called the Kegel exercises. The patient is asked to squeeze her pelvic floor, like if she's have a urine in a socially improper place, and she try to retain her urine. We ask her to do what she do when she want to retain her urine. Yani she will squeeze her pelvic floor to get benefit. This must be done for 3 months, every day, 3 times per day, and you can ask her to do it even if she is working in the يعني daily work, daily activity. You ask her to do these exercises at morning, at midday, and at the night, 2 to 3 times per day. If she can do it 10 to 15 times every time. We have another conservative treatment, which is the devices, which is very ancient instrument used. I think I saw in one of the books they are used from the time of the old Egyptians, and these are inserted either in the urethra or on the external meatus or inserted into the vagina and provide an occlusive pressure on the urethra. So we said that we started with a conservative treatment. If they get no benefit from the conservative treatment, we will shift to the other treatment, which is the pharmacotherapy. And one of these drugs is the duloxetine, which was for many years the only licensed treatment for the urinary stress, urinary incontinence. It is a serotonin and noradrenaline reuptake inhibitor. It inhibits presynaptic uptake and of the motor neurons of the pudendal nerve, and their increase their amount in the synapse. Thus, it will stimulate the striated urethral sphincter, but it have many side effects like the nausea, fatigue, dry mouth, insomnia, constipation, dizziness, and somnolence. The other drugs used for the another cases of the like the overactive bladder are the antimuscarinic drugs like the atropine. It was the first drug, but because of side effect, it was it is not used now for this purpose. We have tolteridine, trospium chloride, we'll have sulfinacine, we have darphenacine, and we have many other drugs. We have a drug with a mixed action with the antimuscarinic and have a direct muscle relaxant and local anesthetic drug, and it's very nice in these cases, which is oxybutynin. It is very effective here. Frankly, I use it with my patients because I told you that these patients, especially in the menopausal group of patients, there are very wide range of these patients who are complaining from the urinary incontinence in all its types, whether it is urge or stress incontinence, especially after the 40s. And I saw a lot of the old women, yani the women who are had even 70 and 80 year of age, they came complaining from this problem. The very troublesome side effect of oxybutynin, and the patient sometimes, although it is effective and can leave it, is the dry mouth and the skin. And sometimes they withdraw the drug because of these side effects. We have many other drugs used here, like the antidepressants. We have the calcium channel antagonists. We have the antidiuretics like desmopressin. And sometimes, as I told you, we saw a lot of these cases in the postmenopausal. And because of the atrophic changes, we can use estrogens for them. And sometimes they get benefit from the estrogens, whether it is local or systemic estrogen. Till now, if the conservative treatment is failed and if the drugs are also failed, we have to do sometimes surgery for these patients. We have many types of surgeries for these patients. For me, in the gynae patient who are complaining from the weakness of their pelvic floor and the prolapse of the urethra or the bladder. We sometimes do what calls anterior-posterior repair for the vaginal wall to slightly to elevate the urethra or the bladder. And sometimes we do what is called birch colbo suspension. This is by tightening the vagina and to hold the urethra by stitches to the pubic bone, and this will lengthen the urethra and increase the resistance of it. We have another types of operation. These are طبعا done by the urologist, which is called the TAVE procedures, and there's a lot of TAVE procedures like the tension-free vaginal tape. This is by inserting a special type of tapes in the vagina, يعني in the on the urethral orifice طبعا in the vagina. To hold it above the, because these patients go down because of the prolapse of their pelvic floor. We have another type of these tapes which is called the transobturator tape. We have the mini tape procedures, and we have also the bladder neck sling operations. We have also what is called urethral bulking agents. These are يعني by inserting or injecting a bulking agent in the urethra. Special طبعا this is done for the men after prostatic surgery, and sometimes if this all are failed, we have to implant an artificial sphincter for these patients. Still, we may have a group of patients who will, especially of those with very intractable detrusor overactivity, who cannot benefit from any of the above treatments. These patients can get benefit from another types of operation, like what we call this clam cystoplasty. This is done by the inserting part of the piece of the small intestine into the dome of the bladder, and we will decrease here the activity of the bladder, of the detrusor. Sometimes even with this it will not get benefit, and we have to do detrusor myomectomy. This is by very severe cases or neurogenic cases. Here we will remove the detrusor muscle will be excised from the dome of the bladder. Thus, we will create a larger bladder diverticulum with no intrinsic contractility. Still, if this all not beneficial for the patient, we will have to do what is called urinary diversion. This is by perform a urinary diversion. This is utilize an ileal conduit. يعني we use part of the ileum to create an incontinent abdominal stoma for urinary diversion. يعني we do like a diverticulum from the bladder by the مثلا part of the ileum to be emptied to the intestine. This is for the very intractable and neurogenic detrusor overactivity.